infectious diseases, so inflammatory reasons, digoxin toxicity, abnormal position of the conduction system and the single ventricle physiology, Epstein anomaly, corrected LTGA. So in DTGA, it's the great vessels that are reversed. In CCTGA or LTGA, it's the ventricles that are reversed. ASD, so if they have an ASD and we're suturing, patching, congenital reasons, cardiomyopathy, so again, that dilated heart, healthy children, post-congenital heart surgery, and then treatment is usually none, or if it was digoxin related, then you would discontinue digoxin. So these in this last section, they're actually just strips from the defibrillator. And so what we're going to do is pretend that the patient is a 16-year-old. So who would like to take us through analyzing this one? We'll just use this 3-second strip and this 3-second strip. Would anyone like to? No takers?
No, the PR interval is prolonged.
Yeah.
More than,
and how many? Yeah.
More than 200 milliseconds.
Okay. Yeah, so if we look at our P to P rate, again, we have 1, 2, 3, 4, 5, 6, 7, 80. And if we look here, so we didn't take him. That would make, because he's kind of on the other side of the line, but we're going to take him. So because we didn't take him, maybe we won't take him. So it's 1, 2, 3, 4, 5, 6, 7, and he's on the other side. Because we took him, we will take him. So we've got 80 Ps and we've got 80 Rs. So we've got one-to-one conduction. But you're right, when we look at the PR interval, and I'm just going to find one that's right on the line. So this guy's right on the line. So there's 1, 2, 3, 4, 5, 6, right? So 6 small boxes times 0.04 is 0.24 seconds. So for a 16-year-old on our sheet, it should not exceed, as you had said, like I think you said 200, which is milliseconds, or that's 0.2 seconds. And in this case, it's too long. So again, we just monitor it, but usually they're not requiring anything. In this, this is a baby. So in this example, we have, again, we'll choose this 3 seconds here. And so in counting the P's, we have this sort of notch looking P here. So we're going to start at the beginning of it and count. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 Ps. And because, yeah, so I'll just start with him. So it really doesn't have much of an R wave. It almost looks just like that sort of QS picture that we were looking at. But if there is, it's very tiny. And there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So we have 140 Ps and 140 Rs. And again, this is an infant. I'm going to find one on the line. So this is on the line. So it's 0.04, 0.08, 0.12. Might even be a bit longer. So 0.04, 0.08, 0.12. So it almost looks like it's, so 1, 2, 3, 4, 4.5 small squares. So 0.18 seconds. So too long for an infant. Okay, second degree Wenke back. So now what we're looking at is an intermittent block. There is going to be more P's than QRS's. So remember at the beginning, we talked about whenever we did the P's and looked at the QRS's, if we had more than the R waves, then we were going to look for second and third degree heart block. So the P waves are present, upright, uniform, but not all of the P waves are followed by QRS's. So they're firing and most of them are going down, but every once in a while the P doesn't go anywhere. It gets non-conducted. And the PR interval, though, progressively gets, so after a blocked beat, you just see a P wave that doesn't go to a QRS. The next beat over, the PR interval starts short, and the next one gets longer and longer and longer PR, till eventually you get a P that doesn't get conducted again, and then the cycle starts all over again. Now the QRS will be narrow because the ones that do get through are starting in the SA node and going through the right and left bundle branch. So they're going through the rapid path conduction pathway. So that creates a narrow complex QRS. So not all P waves are followed by QRS. You have dropped beats. You have a progressively lengthening of the PR interval until a P wave is not conducted. The atrial rate is greater than the ventricular rate. And dropped beats occur over 3 to 6 cycles. And so the effect depends upon, how many beats that you're dropping in a minute. And so it may progress to second degree or third degree. So causes then are myocarditis, so infectious inflammatory, cardiomyopathy, that dilated heart, cardiac surgery, so surgery around the AV node. So again, all of those patients, truncus, DTGA, tetralogy, AVSD, valve disorders, so may end up with, Wenckebach type of block. Ditch toxicity, congenital heart defects, the ones we've listed, Epstein, any kind of valve surgery, and then sleep or conditioned athletes. So treat the underlying cause, monitor and observe for progression of the block. So if it is a slow rhythm, then the usual things that we use to help people who have slow rhythms, so atropine, epi, isoprel, or a pacemaker. And in the congenital heart disease repair, it may be just a temporary pacemaker so that we get AV sequential, in the post-op period. Or maybe they need to they need to have a permanent pacemaker, or maybe we're just going to monitor them. So in this one, let's choose this here. So we have a 3-second strip, and the second little thing is hiding in here. So again, we have 1, 2, 3, 4, 5, 6, 7, 8. We have 80 Ps. And we have 1, 2, 3, 4, 5, 60 Rs. So we have more Ps than Rs. So we're going to, it's not going to be first degree block because first degree heart block has 1-to-1 conduction. So we're going to look to see if it's second degree block or third degree block. So step 1 is more Ps than we have R waves. Step 2 is the R to R regular or irregular. If the R to R is irregular, then we can look to see if it's the second degree heart block Wenckebach or Mobitz 1, or second degree heart block classical or Mobitz 2. So remember, first step, more P's than R's. Second step is the R to R regular or irregular. So if it were regular, then the way I sort of approach it is drop down to see if it's third degree heart block, because third degree heart block, the R will be regular with itself and the P will be regular with itself, but the two won't be regular with each other. So first, if it's irregular, I'm going to start with the twins. This is just a way that I was taught a long time ago that I've always remembered, that a mom had 2 twins that were exactly identical, and they had different dating habits though. So she only knew them apart by looking at their activity sort of going out. So with twin A would go out in this wanky back kind of fashion. So she would go out at 8 o'clock and come in at 10 o'clock. The next night she would go out at 8 o'clock and come in at 12 o'clock. Next night she would go out at 8 o'clock and come in at 2 o'clock in the morning. Then 8 o'clock go out, come home at 4 o'clock in the morning. And then the next night she would stay out at her friend's house and so her mom wouldn't see her for 2 full nights. So her bed would be empty. And so there's a delay. But when she came home, her mom knew that the next night she would go out at 8, come in at 10, go out at 8, come in at 12, go out at 8, come in at 2 o'clock in the morning, go out at 8, 4 o'clock in the morning, and then the next night again. So what you're seeing here is after a dropped beat, the PR interval starts small. That's a good reason to remember to not only when you're doing PRs measure one PR, but make your paper or your calipers go across to measure to see if there's a pattern. So this pattern for this twin, Wanky Back Mobitz 1, was progressively length after a dropped beat where her bed is empty, there's a delay in her mom seeing her, she has a short PR interval, progressively lengthening, staying out longer each night till she just doesn't come home. And then it continues. And that differs from second degree AV block classic Mobitz 2. So again, Mobitz 2, you have more P's than you have QRS's, but the pattern of your PR interval is different in that every time you measure a PR interval, it is exactly the same. So conduction is blocked high in the bundle of His. Not all P waves are followed by a QRS, so there are drop beats. Sudden dropping of the QRS, and there can be, dropping so having 2 P waves or dropping after 2 conducted beats, or having 3 and then dropping, or 4 normal ones and then dropping. But we're not seeing the lengthening of the PR interval like we were before. And we're going to monitor for progression to third degree heart block. So the reasons are, again, myocarditis, cardiomyopathy, post-cardiac surgery, myocardial infarction, so many of the same reasons. And then again, we're going to treat the underlying cause. If they're bradycardic, you could use isoprel or epinephrine or a pacemaker. So when we look at this diagram and see how it differs from the previous one, so we'll use this this strip here. In this one, we're going to count the P waves. So there's 1, 2, 3, 4, 5, 6, 60 P waves, and 1, 2, 3, 40 R waves. So 60 Ps, 40 Rs. So one thing we need to be concerned about right now is that patient's tolerance for 40 R waves. Are they okay in their managing, or are you starting compressions? So step 1 is there are more Ps than Rs. So we had 60 Ps and 40 R waves. Step 2 is the R to R regular or irregular. So if we dropped every second QRS, then actually you would have a regular R to R. But if you have a regular R to R, I would just go down and see if it's third degree heart block first. And remember, in third degree heart block, the Ps just are doing their own thing and the Rs are doing their own thing, but they're just not talking to each other. So if it didn't fit that criteria, then you would come up to second degree classical, which could have a regular R to R cycle. But when we look at this, we have 60 Ps and we have 40 Rs. So step 2 is the R to R regular or irregular? Well, in this particular example, the R to R is very irregular, right? There are 3 Ps that don't get, well, that one gets conducted, but these 2 don't get conducted. So going back to the mom with the twins, this is the other twin, and mom knows that after a blocked beat, that her dating habit is always the same. So she goes out at 8 o'clock and comes in at midnight. 8 o'clock goes out, comes in at midnight. 8 o'clock goes out, comes in at midnight. Her PR interval is very consistent or very classical, and that's what we call Mobitz 2. But then she stayed out and didn't come home here, so her mom didn't see her. That's why the R to R is regular. She actually, in this particular instance, stays out a second night, and her mom doesn't see her. But her mom knows that when she does come home, that she will go out again at 8 o'clock and come home at midnight. So when you're thinking of the blocks, one way to think of it, step 1, more P's than R's. Step 2, is the R to R regular or irregular? If it's regular, drop right down to 3rd degree heart block and see if the P's all map out with themselves and the R's all map out with themselves, but they're slower. But the P's and the R's don't have anything to do with each other. They're asynchronous. And if it doesn't fit that, come up to see if it's the classical Mobitz types 2, where the patient, where the beat is dropped every second beat. So with 2nd degree heart block, remember, more P's than R's. If you look to see if the R to R is irregular, you're going to look for the twins and their dating habits, which is basically looking at the PR interval. In Wenke-Back, the PR interval progressively gets longer each night till she stays out with her friends, and so her mom doesn't see her, so there's a gap in time making the R to R irregular, but she knows when that twin starts going out again, it's going to be a short PR interval conducted to a QRS, and then it'll get longer, the PR interval, and longer till we just see a P which does not get conducted, and then the cycle will start with short, longer all over again. In classical, there's more P's than R's. If the R to R is irregular, you're going to look then for step 3, which is the PR interval. What is the pattern of the PR interval? If it's progressively lengthening PR interval till a P wave drops a QRS, then it's Wenke-Back or Mobitz 1. If, however, like this picture, every time you measure a PR interval, even after a dropped beats, the PR interval is consistent or classical, then it's 2nd degree, classical or Mobitz 2. 3rd degree block is you have sort of 2 pacemaker sites again, or 2 pacemaker sites. So this is a complete block. Nothing from the SA node goes through to the, to the ventricle. And so depending on where the block is, if it's higher up, then there's an opportunity for the AV node to help out the ventricle. But remember, the AV node will fire at about 40 to 60 beats per minute, and the QRS will be narrow. If the block is lower, then the SA node will go to here, but it won't progress to the ventricle, and it'll be the Purkinje fibers that help out the ventricle at a rate of 20 to 40 beats per minute. And the complex, because it's Purkinje fiber, will be wide and bizarre. And their PR interval, there will be no association. The P waves are just mapping out with themselves. Sometimes they get lost in the QRS. And the R waves are mapping out with themselves at a slower rate, but the 2 are not coordinated with each other. So it's asynchronous, disassociated P waves from the QRSs. So this is just showing you, depending on your age, whether you're an infant, a child, or an adolescent, in 3rd degree block, what your heart rate might be based upon a sinus rate, so 120 to 160 for the infant. A child will be somewhere a little bit slower than the infant, but it's age related. So depending upon the age, and then you and me as 60 to 100. If the R to R is being supported via the ventricular rate is being supported by the AV node or junction, then it will have a rate of 50 to 80. But again, the rate might be a bit higher than that. But those are just sort of giving you an idea that it's the rate plus the morphology of the beat that helps you. So an infant or child, the rate for the junction, maybe a bit faster than the ventricular, which would be 20 to 40. But still both will be slower than the SA node. So the effect is no consistent relationship between atrial and ventricular activity. The P waves and QRSs march through at their own independent rhythms. You know, and it might be transient, post-surgical repair, swelling, inflammation, that we may need to pace you, AV sequentially pace you with a DDI pacemaker until, you know, the heart, everything, the cells sort of fix themselves and the swelling goes down. Or maybe it does need to be a a permanent pacemaker put in. So causes are maternal lupus, congenital reasons like, so lupus would be an example of that, a baby born from a mom with lupus, idiopathic for no known reason, post-cardiac surgery, around all of those things that center around the AV node. Myocardial infarction, myocarditis, congenitally corrected or CCTGA or LTGA, dig toxicity, hyperkalemia, and then treatment, you know, it depends on, you know, what their symptoms are. If they're too slow, then atropine, epinephrine, isoprel, and pacemaker. So here's a good diagram on, or good strip, I should say, on third degree heart block. So, you know, there's our 3 seconds, there's halfway in the 5 there is our 6 seconds. So we're gonna count up the P's. So when we're doing our P to P and R to R, we get more P's than R's. So here we have 1, 2, 3, 4, 5, 6, 7, and remember our little line stops there. So we have 70 P's, we have 30 R's. Knowing that we have 30 R's, we have to decide how the patient is tolerating it. Likely they're going to need compressions. And so step 1, more P's than R's. We have that, 70 P's, 30 R's. Step 2, is the R to R regular or irregular? Well, our R to R is very regular. So if your R to R is very regular, let's drop down to third degree heart block first and see if it's that. And if not, we can come back up to second degree heart block, classical or Mobitz 2 type. So in this, if we look, it looks like if we took our calipers and measured here, it looks like our P to P would map out with each other. And probably it's gotten lost in here, so we just don't see it, but it actually maps out. Okay? So the P's look like they're, you know, having a party with themselves, and the R's look like they're doing it with themselves, independent of what's going on. So there's no association between these P waves and the R waves. P's are doing their own thing, R's are doing their own thing, and that, so we could stop at third degree heart block. If that doesn't fit, we could move back up to second degree heart block, classical, where the R to R is in fact potentially regular because it's dropping its QRSs at a very regular beat. So for instance, if it was dropping every second one, then the R to Rs would map out with themselves. Okay, so that is cardiac arrhythmias. Of course, there'll be many opportunities to continue to practice and discuss different aspects of it throughout the year. So we're going to have Faith come and do some practice packages. We're going to have Dr. Amar Jiwa come in semester 2 and review cardiac arrhythmias. We have full 15 lead interpretation in semester 2. We have, as I said, Dr. Anitzia Bullock coming to talk about just specifically the cardiologists, the atrial arrhythmias, atrial fib, atrial flutter, AIRT, AVRTA, NRT. We also have Dr. Beth Stevenson in semester 2 talking about junctional ectopic tachycardia. So Winnie is waiting for us. So I'm just going to stop the recording. Before I do, does anyone have any questions? Okay, so let me just stop the recording, just wipe down the counters and restart.